This is the second presentation for Servier Symposium with a new approach of heart failure optimization. This is my disclosure. هبتدي بريال لايف كيس دي كان فعلا patient انا كنت شفتها دي 68-year-old female. She is a retired physician. She had multiple comorbidities in the form of diabetes mellitus, hypertension, dyslipidemia, and hypothyroidism. All of these factors were controlled. Her presentation after having a COVID infection, 2 weeks after having COVID infection, she started to experience progressive breathlessness, palpitation, BNDs, and orthopnea. And her examination showed a heart rate of 120 beats per minute regular, her blood pressure 140/90, elevated jugular venous pressure with fine bilateral basal crepitation, S3 gallops, and ankle edema. Her ECG showed sinus tachycardia. ما كانش في عندنا ST segment deviation ولا Q waves موجودة في ال ECG. Her echocardiography showed dilated left ventricular dimension 6 and 5 centimeter, ejection fraction of 34%. Global hypokinesia, however, there was some regional motion abnormalities involving the posterior and inferior wall. There is a moderate mitral regurgitation, dilated left atrium, mild tricuspid regurgitation, pulmonary hypertension, mild pericardial effusion. So the problem list, we have a patient with HFrEF وهو يعني some differential diagnosis. طبعا اللابس اتعملت for this patient and all labs were normal. Kidney function, thyroid actually she was hypothyroid, however her thyroid profile was normal on treatment. This may be myocarditis after COVID. Might be a coronary artery disease. She had multiple risk factors. However, we did a coronary angiography while during her hospital stay. It was normal. Cardiac MRI also was done for this patient and revealed no signs of inflammation. So we are kept with the diagnosis of HFrEF. This was her comorbidities, and the initial treatment was in the form of IV diuretics, then shifted to oral diuretics after compensation. ARNI, she was in a good dose of ARB, so we shifted to ARNI 100 milligram twice. Started a beta blocker after reaching dry weight of 3.125 twice, dapagliflozin, eplerenone, and acetyl salicylic acid. Despite all this medication, when in hospital, she has a heart rate of 100 beats per minute, and this was the problem we are going to address in this presentation. So my goal today is we're going to study a special drug which is ivabradine, to know the additional value of adding ivabradine in HFrEF patient on top of 4-pillar therapy, and define the different profiles of HFrEF patient that can benefit from ivabradine, and identify the best timing to start ivabradine in HFrEF patient. To start, we have multiple problems regarding the HFrEF patient. The economic burden, and the economic burden came more from the hospital admission, as well as we all know that hospitalization and rehospitalization will increase the morbidity and the mortality of heart failure patients. So we need to cut this vicious circle. And to do that, we need to know what is the predictor of rehospitalization. There is multiple predictor of rehospitalization, such as not reaching the optimum decongestive state, elevated discharging the patient despite being congested, elevated biomarkers, the presence of multiple comorbidities, and two important predictors are elevated heart rate and lack of compliance to medical treatment. فبالتالي ممكن ان احنا to study different profile of patient. دي كانت position statement released by European Society of Cardiology for the different profile of heart failure patient, and it based on 4 criteria: normal heart rate, blood pressure, the presence or absence of atrial fibrillation, and CKD. فلو شفنا في profile of patient وهو احنا بنشوفه وهو بيبقى patient ممكن نقول عليه بيبقى difficult شويه، اللي هو بيبقى عنده tachycardia meaning heart rate هنا في الاكزامبل ده اكتر من 70 beat per minute, with low blood pressure. Low blood pressure is borderline 90/60 or less. This patient actually we try to introduce a 4-pillar therapy. However, ممكن ان احنا ما نقدرش introduce all these medication أو لو هنintroduce them هنintroduce them with a small doses. So in this patient اللي هو بيبقى عنده الهارت ريت rapid heart rate, we can introduce a drug like ivabradine. Ivabradine can achieve الحاجة اللي احنا محتاجينها with a reduction of heart rate in addition to multiple hemodynamic effect هنقول عليها في السلايدز الجاية that can help our heart failure patient. مش بس كده، هم في الستيتمنت قالوا كمان ان احنا ممكن نحط او نقاد الإيفابرادين in the patient with a heart rate with 60/70. This may be especially in the patient who cannot tolerate the beta blocker. ممكن these patient benefit من الإيفابرادين. In addition to that, of course, if we still have our patient on 4-pillar therapy with a heart rate over 70 beats per minute, even with a good blood pressure, ivabradine can be a good option in this situation to control the heart rate. Based on that, we have guidelines. We have the European guidelines that give the ivabradine a class 2A to be given in the patient with symptomatic heart failure, sinus rhythm, ejection fraction less than 35%, with a heart rate more than 70 beats per minute despite beta blocker. We can use them on the top of beta blocker, and we can use ivabradine if the beta blocker is not tolerated in HFrEF patient. فمن هنا جاءت يعني الإيفابرادين أو الرول of ivabradine in the HFrEF patients زي ما احنا قلنا to be added in the patient sinus rhythm, ejection fraction less than 35 and resting heart rate more than 70 beats per minute. And the important statement ده according طبعا للشيفت ترايل ان هو it was shown to reduce heart failure hospitalization and cardiovascular death. American guidelines came in agreement with the European guidelines and added a similar statement for ivabradine in HFrEF patient. فدي كانت الكونكلوجن بتاع different guidelines والposition statement for the importance of this combination therapy, which is a beta blocker in addition of ivabradine in the patient with chronic heart failure especially. فده برضو بيجي من الرول بتاع الإيفابرادين والإفكت بتاعه ان احنا بنقدر with the reduction of the heart rate لما بنشوف في الاستادي ده reduction of heart rate very early can be associated with increase in stroke volume. ده يمكن حاجه ما بتبقاش especially في الانيشيشن of beta blocker. With the initiation of beta blocker we can have a negative inotropic effect. احنا لازم نعترف طبعا ان البنفيت بتاعت البيتا بلوكر مهمه جدا واssociated with a mortality reduction in the patient of heart failure. However, initially the ivabradine can have a good hemodynamic effect. With a reduction of heart rate, we can have an increase in stroke volume, and this can maintain the cardiac index in this acute patient. الداتا اللي قبل كده اللي كانت موجوده عندنا من البيشنت with chronic heart failure. However, يعني في increasing data of the use of ivabradine in acute heart failure patient or stabilized acute heart failure patient. يعني بندي الإيفابرادين before hospital discharge. خلينا نكون يعني انا يعني اعتقد ان في امانه مع النفس ان في كتير مننا ممكن بيعمل البراكتس ده يعني من فتره حتى before the data ان هو ممكن يبقى بريسكرايب الإيفابرادين for a heart failure patient، ودي طبعا هتبقى point of discussion بعد كده. لكن هو ده بيزد على في داتا دلوقتي بتقول ان هو ده ممكن يبقى beneficial. فلو شفنا في الترايل ده ان الاديشن اوف ivabradine to beta blocker before hospital discharge was associated with the improvement of ejection fraction عند ال 4 months وعند ال 1 year زي ما احنا شايفين هنا في الداتا دي. ودي داتا مهمه جدا جت ليتلي في السنه اللي فاتت، هي جايه بصراحه من 2 large registries عن ال use of procorlan او sorry ivabradine in the patient with HFrEF before hospital discharge. وهنا كانت بتبص على hard clinical outcome مش ejection fraction، على الهارد clinical outcome. And it was shown in the addition of ivabradine to beta blocker before discharge can reduce cardiovascular death by about 55%. So it's it's an important addition for our heart failure patient. This also was associated with a reduction of the rate of heart failure hospitalization. زي ما احنا شايفين at 1 month there is a significant reduction of heart failure hospitalization at the all interval 1 month, 2 months, and 3 to 6 months. So beta ivabradine with beta blocker combination in acute heart failure patient before hospital discharge can decrease cardiovascular death and can decrease heart failure hospitalization. This was in agreement with the old data اللي جت من الشيفت ترايل. الشيفت ترايل برضو كانت بينت ان في البيشنتس اللي هم كانوا على ivabradine as compared to the control group, those patients showed a reduction of a heart failure hospitalization at 1 month. عشان نكمل كل البنفيت بتاع الافابرادين دي برضو كان في من شيفت ترايل. The ivabradine in combination with beta blocker was also associated with a reduction of death from heart failure, cardiovascular mortality, and all-cause mortality, especially in the patient with a heart rate more than 75. As we all know, احنا عندنا في multiple beta blockers that can be given in heart failure patients. أهمهم هم الكارفيدولول, الميتوبرولول, and bisoprolol. One of the most studied drugs هو الكارفيدولول. والكارفيدولول زي ما احنا شايفين هنا studied in the two trial هما اليو اس كارفيدولول and كوبرنيكاس trial. في واحده فيهم زي ما احنا شايفين المورتاليتي ريدكشن كانت approaching 65%، الثانيه كانت 35%. ف the carvedilol was associated with a marked mortality reduction and a prognostic improvement in heart failure patient. With number to treat هنا في الكوبرنيكاس trial of 14 patients. So carvedilol is a good drug. وده برضو بصراحه يعني زي ما بنشوفه في الكلينيكال براكتس الكارفيدولول is one of the heart failure drugs that can used and can be up titrated safely in the patient with heart failure. طبعا بعد الوصول للدراي ويت. فلما نيجي نحط التو pieces of information مع بعض كارفيدولول and ivabradine ونبص في this sub study of shift اسمها shift carvedilol sub group. Addition of ivabradine to carvedilol was associated with the reduction of cardiovascular death or hospitalization for heart failure, in addition to a reduction of heart failure hospitalization and cardiovascular hospitalization. In another trial, this combination also was associated with a better quality of life very early at 3 months with a fewer symptoms and better exercise capacity. So Servier دلوقتي هي طبعا طلبت مننا احنا يعني this molecule is formulation is introduced in the market with carvedilol and ivabradine combination. وهو by giving our patient this combination we can have a more compliance in a single pill combination in two drugs that was associated with a mortality reduction in the heart failure patient and less number of drugs. دي السلايد بس احنا بنعرضها علشان نبين هو ايه الفورميوليشن بتاعتنا اللي ممكن ان احنا نستخدمها for these molecules. We have a carvedilol 6.25 with 5 milligram ivabradine and 7.5 milligram ivabradine, and we have a carvedilol 12.5 milligram in addition to 5 milligram and 7.5 milligram ivabradine. So if we need to increase the dose of beta blocker, we have the option to increase the dose from 6.5 to 12.5. And if we have a concern regarding the blood pressure and we cannot increase the dose of beta blocker, we can increase the ivabradine dose from 5 milligram to 7.5 milligram. So back to our patients, in addition to the 4-pillar therapy and after escalating the beta blocker dose, we have the option to give our patient the carvedilol, carvedilol, and ivabradine combination in a dose of 6.25 to 5 milligram twice daily. 1 month after follow-up, the patient was asymptomatic regarding the heart failure with a good heart rate control of a 65 beat per minute. So to conclude, ladies and gentlemen, we have a very long trip of our heart failure patients, starting with hospitalization, then going to discharge, and back to hospitalization again. We need to cut this vicious circle. we can cut this vicious circle in the hospital by addressing all the comorbidities of our patient, especially the heart rate. Heart rate can be reduced with beta blocker, of course, and with ivabradine use very early, as we shown in our presentation, that it can be associated with better outcome. After discharge, we can help our patient to decrease rates of hospitalization and actually also to decrease the mortality by increasing the beta blocker dose and increasing heart rate control. And this can be done with a combination of carvedilol, ivabradine, or with increasing dose of ivabradine. And thank you.